Okay. So I'm basically going to tell you a story first and then come to a few conclusions based on that story. And the story is the sad story of fee-for-service in the US over the past 50 years. From 1975 to 1997, I finished training in 1979, started private practice of psychiatry as well as working part-time in employee jobs. Um, And in the early days, we were paid with fee for service. There were minimum documentation requirements. You basically could write whatever you want as your note, and everybody used fee for service. They had recently passed Medicare and Medicaid into law in the early 70s, so I had the benefit of those. At that time, I am aware of some abuse of fee for service with unnecessary procedures for financial gain, but it was mostly with hospital employed procedural specialists. And I've never seen any evidence of abuse of fee for service from primary care specialties. In about 1990, CMS added what I consider to be appropriate general documentation guidelines. Basically, following the medical model, you needed a reason for the visit, interval history, relevant exam, lab and imaging, assessment, diagnosis to justify medical necessity, a plan, and a signature. And to me, that was a reasonable expectation, and I was happy to comply with that. In 1992, CMS introduced the resource-based relative value system to assign relative values to each of thousands of procedure codes. And they convened a resource-based update committee by the AMA, mostly dominated by specialists, to update this at regular intervals. There were four components of fees: work, practice expense, malpractice cost, and a geographic adjustment called the GPCI, which is based on an extremely complicated mathematical formula. If you want a headache, you pull up CMS on the GPCI and try to understand it. Um, I would say that the RUC has never effectively updated any of these components, and so the whole system has become quite skewed. It was also operating under the sustainable growth rate formula, which Congress imposed, saying that if cost of healthcare exceeded the general cost of living, consumer price index, that it would result in automatic cuts to fees. And Congress kept deferring this because they realized it would drive doctors out of Medicare. So the size of the cut that was hanging over our heads kept growing until it was like 25% of your pay was about to be cut if they didn't defer it the next year. And they also had budget neutrality rules. So if you raise pay for primary care, you have to cut it for specialists. And the RUC was dominated by specialists, and they didn't want that to happen. So the result was a widening pay gap between procedural and cognitive specialties. In the mid 1990s, Medicaid managed care was introduced. Many states started privatizing their Medicaid programs, and by the early 2000s, three-quarters of Medicaid beneficiaries were under private managed care plans. And the result was a proliferation of prior authorizations for both visits and drugs, declining physician participation, which was particularly dramatic for psychiatry, increased reliance on urgent care, emergency rooms, and hospitals for care, and accelerating cost increases. Also, in 1997, Medicare Advantage was initiated, which is private full risk capitated plans within Medicare in competition with traditional fee for service Medicare. The rules were skewed to favor Medicare Advantage plans who relied on gaming the payment system for profitability. They generally did little or nothing to actually improve care. It was all based on gaming the payment system. This includes flawed benchmarking methodology, gaming the risk pool with cherry picking and lemon dropping, gaming risk adjustment with upcoding, arbitrary use of prior authorizations to not deny or avoid paying for care. And because capitation allows unspent funds to be kept as profit, this is an incentive for profiteering and a portal for profiteers in healthcare. The result was escalating unreimbursed administrative demands imposed on doctors. Fee-for-service Medicaid still uses very few prior authorizations, but Medicare Advantage uses a lot. All the forms of gaming listed on the last slide require detailed data from doctors. and CMS began requiring escalated, unreimbursed administrative data from physician practices. Also in 1997, CMS imposed new documentation guidelines for evaluation and management services, which is what primary care doctors and psychiatrists use. Generally, any especially doing cognitive services use E&M codes. Payment was now based on adding up elements in the note, the number of elements of the history asked, and exam performed, or at least allegedly done, because many doctors claim to have asked or done things they didn't actually do. The time, effort, and complexity and decision-making and stress were all supposed to be included in calculating how much to pay. And the result was the length of notes more than tripled. Accuracy of notes deteriorated because of cloned information from prior notes not updated for accuracy and false data inserted into notes to increase payment. Lots of useless information was added, so reading a chart became almost impossible to understand. And there was more and more unreimbursed time for physician practices. 2004, CMS noted that Medicare Advantage plans were gaming their risk pools with cherry picking and lemon dropping, and the risk adjuster was based on demographics, and it only predicted individual risk with 1% accuracy, which was no deterrent at all to gaming the risk pool. So they added diagnostic categories to the risk adjuster with the hierarchical conditions categories formula. This increased the accuracy of predicting individual costs from 1% to 11%, which is still no deterrent to cherry picking and lemon dropping from within categories. The HCC tied payment to the details of diagnostic coding for the first time and required maximum diagnostic specificity. Medicare Advantage plans quickly discovered that they could get more money out of upcoding than they could by gaming the risk pool, so they started relying heavily on upcoding. Meanwhile, from 1997 to 2012, psychiatrists were faced with time-based codes that bundled evaluation management services with psychotherapy in a single time block. And more than 95% of codes used by psychiatrists were just 4 time-based codes: 1 hour for a new evaluation, 45 minutes combined psychotherapy and E&M, 30 minutes for combined psychotherapy and E&M, and 15-minute brief visit for stable patients who just needed a check-in and prescriptions renewed. But in 2013, psychiatrists were put on the same pay-for-documentation E&M codes as primary care. And in my own 5 psychiatrist group practice, I looked at the charts for same doctor, same patient in 2012 versus 2013, and the length of notes more than tripled overnight when this system went into effect. There was increased unreimbursed documentation time that cut into both patient care time and personal time for the doctors, and the practice of psychiatry became substantially less efficient as a result. 2011, the Affordable Care Act passed and blamed high cost on fee-for-service driving unnecessary care, which was never true. We never had excessive utilization in the US under fee-for-service. So this is just a false rationale that was used by profiteers as an excuse for inserting themselves into healthcare. Affordable Care Act promoted value-based payment and capitation, using upfront payment that is supposed to reward value, not volume, and holds doctors and hospitals accountable for outcomes and costs of care that are largely outside their control. The Affordable Care Act discourages fee-for-service and promotes alternative payment models with full or partial capitation, and relies on financial incentives to manage physicians instead of trusting their intrinsic motivation. Alternative payment models promoted by CMS and the Centers for Medicare and Medicaid Innovation include accountable care organizations, direct contracting entities, REACH, realizing equity access and community health, Maryland, total cost of care budgeting for hospitals, AHEAD, advancing all payer health equity approaches in development. All of these involve capitation or partial capitation of organized groups of doctors and hospitals. Then in 2015, Congress passed the macro law, which finally repealed the sustainable growth rate formula and replaced it with financial incentives for doctors to join alternative payment models or report detailed computerized data on utilization and quality metrics under the MIPS program, or else CMS would progressively reduce fee-for-service fees starting in 2017. Budget neutrality rules remained in force so that there are still threats of reduced payment every year, and there are still pitting specialists against cognitive procedural specialists against cognitive specialties. In 2021, CMS started allowing time-based E&M coding. This means you have the option of just recording the total time you spent on the care of a patient, including face-to-face time, documentation, and care coordination time done on the same day as the visit. Pay for documentation by counting elements was no longer required, but remained an option. To me, this is the first positive change that CMS made to fee-for-service in this entire story. With the exception of those time-based coding since 2021, every one of the changes to fee-for-service since 1997, when Medicare Advantage and Medicaid managed care were introduced, was implemented to enable capitated corporate intermediaries to obtain the data they needed for risk management and for their managers to pretend they could manage care better than doctors. All of them were in service of the corporatization of healthcare. What is the cause of excessive cost and dysfunction in U.S. healthcare? Waste, fraud, and abuse due to corporate profiteering far, far exceeds any abuse of fee-for-service by doctors and hospitals prior to privatization of Medicare and Medicaid. And you've all seen this graph before, but just to remind you what's happened since the 1970s. And you'll notice that there's a spike from the managed care area in the 1990s and another spike since 2015 due to the Affordable Care Act and the movement to value-based payment. So my question is, what is the payment sweet spot? Where in all this should we have stopped? And I would say fee-for-service using time-based codes now allowed by CMS, including time for documentation and care coordination, going back to the documentation requirements in force prior to the 1992 RBRVS system, which is basically just reason for visit, history, physical, lab, assessment, diagnosis, and plan, just that. And eliminate capitated fiscal intermediaries, which means no profiteering, no need for pay for documentation, no detailed diagnosis coding or tying diagnosis to payment, no upcoding, no value-based payment with its perverse incentives and high administrative costs. If we had just time-based fee-for-service, administrative costs for the payer would be less than 2%. There would be no pay for documentation, and documentation would be focused on patient care, not billing. Diagnosis would be used for medical necessity only and not tied to payment. Payment would pay for the value of the time and expertise of the professional performing a procedure instead of trying to assign relative values to the procedures themselves. It would be incentive neutral for choice of treatment, and doctors could choose the time needed and not be punished for taking on more complex and time-consuming patients. It would result in very, very simple billing and collections and minimize overhead. I believe that a well-designed single-payer system should have community-based interdisciplinary teams to assist primary care in managing high-risk, high-cost, and frequent ER utilizers in the community. These teams would help ensure that patients stayed on their treatment plan, take their prescribed medications, make it to their appointments instead of going to urgent care or emergency rooms, that they can be monitored at home when necessary, etc. And we also need programs for special needs patients such as the seriously mentally ill, substance abusers, and geriatric services, including daycare programs, home visits, and consultations. I would like these to be community-based and readily accessible to any independent physician practice based on patient need. You just call the number and they'll come in and help you out. I would also add community-based specialist consultations following the collaborative care model developed at U of Washington for psychiatric consult to primary care. I was the pioneer for this model in Hawaii since 2017. And CMS has procedure codes for the collaborative care model where the primary care doctor submits the code, collects a copay from the patient, and has to reimburse the psychiatry team who are consulting to them. And everyone in Hawaii has had trouble making this work, and all over the country, collaborative care programs have had trouble covering more than 80% of their costs using fee-for-service payment. What Hawaii did is there was only about 6 insurers here, which made it easier. We went to all of them and got them to fund the program directly so that we were able to eliminate any fee-for-service billing. Basically, the collaborative care team has a budget, the professionals are paid with salaries, and they consult to primary care free of charge to either the primary care practice or the patient. And we are able to cover all of the psychiatric needs of the primary care practices without and cover our full costs 100% and offer our services independent of the patient's insurance status because we don't do any fee-for-service billing. Our notes are focused on what the primary care practice needs to know instead of on billing, and there's no financial incentive to over or under treat, and we have demonstrated substantial reduction in emergency and hospital use and impressive results in improving symptoms. The model works really well. You could also apply the same model to any specialty consultation to primary care. You could do rheumatology, infectious disease, adult congenital heart disease, anything requiring specialist expertise, make it available to primary care as a free consult instead of having to refer all those patients out for direct care. And the team can then ensure when direct care is needed, assure medical necessity, and arrange referrals when needed. So let's look at Connecticut. They deprivatized their Medicaid program by firing their managed care organizations in 2013. They hired a formal nonprofit managed care plan as a non-risk administrator for specified tasks, but not including the risk of paying claims. Connecticut Medicaid paid those directly, and the result was that it cost them 15% to administer of the administrative costs of full risk managed care plans. So they cut their administrative costs by 85%. They used some of that savings to raise primary care pay to Medicare levels, added care coordination fee for patients whose primary care practice was designated to coordinate their care, and they added community-based programs for high-risk, high-cost patients and special needs populations. So they implemented a lot of things that I just recommended. The result was immediate 13% of their budget reduction from non-risk administration, 3% of the budget invested in improving primary care and adding community-based programs, 33% improved physician participation in Medicaid from the first year, and improved access to primary care was followed by declining ER and hospital utilization. And after 5 years, Connecticut was spending 15% less per beneficiary than during the last year under managed care. I believe Connecticut results could be further improved by adding community-based specialist consults along the lines of collaborative care model for an array of specialists. This would enable primary care practices to deliver specialist-informed care in the primary care setting, including in remote, rural locations, and further reduce ER and hospital utilization for the whole program. This would be especially helpful to support primary care in remote areas. So, strategy for 2026. We start with pushing states to deprivatize Medicare in as many states as possible, along the lines of what Connecticut did, making Medicaid a state-based single-payer system and using time-based fee-for-service for evaluation and management codes. We could then demonstrate the cost effectiveness of this kind of single payer administration and enable primary care to manage and coordinate care, not insurance plans, make the practice of primary care rewarding again, allow expansion of the primary care workforce and improved patient access to care, and reduce total costs by markedly reducing administrative costs and reduce reliance on urgent care emergency rooms and hospitals. The savings will help states cope with impending cuts in federal Medicaid funding due to hit in a little over a year from now. To me, this is the best opportunity to move in the direction of single payer in a decisive way. It would cut into the dominance of healthcare by corporate interests, and it would be the way out of having to impose drastic cuts in services when federal Medicaid cuts kick in next year. And I think if we can do this, we will go a long way toward showing that single payer is the way to go, and it would be led by the states. That's it. There's some resources here on the slide. I'll put this PowerPoint, which is basically my notes, into the chat. So if any of you want it, you can click on the links and get these resources. And I'm open for questions.
Thank you. Thanks so much, Steve. That was excellent. Particularly intriguing, the last couple slides. We do have a question in the chat from Sam Metz. Do you want to, you're going to drop this link into the, there we go. I just wanted to pull that down. Mike, you could maybe spotlight Steve, if that's all right, for the screen. And then we do have a question in the chat, and then either other folks funnel your questions into the chat or raise your hand. There's a little icon at the bottom of most people's screens. Just click on raise hand and then click the link for that. Yeah, let's get into some conversation and some questions here. So I've got Sam Metz asking if you see it also. Have any other states mimicked Connecticut's Medicaid format?
No, there are several states that are trying to work on it, including Hawaii and Minnesota in particular. I think New York is also has some plans in the work. But there's been a lot of interest in the PNHP Medicaid deprivatization report from around the country. And so there may be a lot more states trying to follow suit. Um, we've we've drafted a bill in Hawaii to implement this, and a lot of other states are picking it up and drafting their own bills based on that as a template. So there's movement afoot, but so far no one else has pulled it off.
Okay. Sam, hopefully that covers the totality of your question. Then I have a couple more in the chat, and then we'll turn to people whose hands are raised. So that would be Sherry McAvoy. And tell us where you're from, Sherry, in the chat, or you can come up and ask your question. And then Barbara Harrison, who I know is from New York. And then we'll turn to the folks with hands raised, Carla San Antonio German. So we got four folks in the queue right now. Sherry McAvoy's question, how close is Hawaii to achieving single payer?
Hawaii been out of practice for economic reasons. So we have a task force to address this problem, and I'm on it. And I have been really pushing Medicaid deprivatization as a major part of the solution to the problem. And as far as I can see, all the active physician participants in that task force are on board with the idea, but some of the people from the state administration are reluctant, even though they have no better option. But I think it's fairly likely to move forward. And I've also got some key legislators on board with this. So our legislative session starts in January. We'll see what we can do. We have the bill ready to go.
Okay. Keep fighting on that front. The next question is looks like from Barbara Harrison, having to do with Wiser, which is what?
That's
Wasteful,
that
inappropriate service. Yeah, go ahead.
Now, that's Medicare trying to
Right.
impose, um, it's a capitated, uh, I'm trying to remember exactly how Wiser works, but it's trying to force states into capitated arrangements, by CMS fiat, whether they want to or not, within traditional Medicare.
Mhm.
So it would basically gut fee-for-service Medicare in those states.
Mhm.
I think it's a very bad idea.
Yeah. What can folks do to push back on this really fraudulent effort to gut our public
I,
health?
I would go to the PNHP webpage. They have a project to try to fight Wiser around the country, and they you can tie into whatever is going on in that fight. They have handouts that people can use in talking to legislators. All that stuff is all ready to go on the PNHP website.
Mhm.
Anna Manilow did from National Single Payer did a presentation on Wiser, and they want to take 6 states as a whatchamacallit, that 6 states to begin the process of trying this out. And there are 17 illnesses that they are going to clamp down on, and they're going to make physicians' lives really miserable.
It
I,
would be imposing widespread prior authorizations in traditional Medicare using artificial intelligence.
yeah, good
It's
luck.
really
Oh, God.
scary.
Yeah, I can't stand that. And I've been interviewed by an AI, and they want to use them to read your resumes. And we're not a great community-oriented country to begin with, but we're losing more and more and more of it. We need you to go back when these kids that are coming up with the AI in the chat box are going to have all these
Yeah.
lack of social skills. You're going to
Right.
need to go
Right.
back to work.
Right. Thanks, Barbara. Appreciate that. Yeah, we'll stay focused on that topic as well. I'm going to flip over to the folks who had hands raised because then a few more people came in with chat questions, I think. So let's go, Steve, over to Carla Sand. And just tell us, as you come up, just tell us where you are, where you're based, even your organization outside of one pair states, and then Antonio, and then or Tony, and then Mike. Carla?
Okay, this is Carla Sand in Minnesota, and I'm calling from the disabled and the senior population, which is what my question is about. We're heavy users of our healthcare system, but I'd like to hear a little bit more about that care coordinator system and how it would work, who's qualified, what they will do, because caregivers or care coordinators are a central part of any senior or disabled person, and they're hard to come by right now. So help me out on that, please.
I think that many Medicaid programs have some of these community-based services. Uh, Sometimes they're under the auspices of the managed care plans where they have case managers, where they have capacity to do home visits, but it's very fragmented. The managed care plans are really more interested in checking the boxes that they're complying with their contracts with the Medicaid department than they are in actually helping with care. And I have seen a lot of burnout among the case managers because they realize their job is basically BS. They're just making a phone call once a month to say they made contact but not doing anything. Um, so what happened in Connecticut is they took one of the managed care companies, which had been hated as a managed care company, and made them the administrator to support these kind of community-based services, which they expanded. And they went from being a hated managed care company to a much appreciated support and enabling care coordination in the community. And the primary care doctors now they had one phone number to call if you needed help with the patient. You'd have a team. Usually there's a part-time physician involved. You have nurses, you have social workers, you have case managers who can go into the community, make sure patients get to their appointments, check on them to see if they're taking their medicines properly, look at their apartment, see what kind of living conditions they're in, those kind of things, and um, and then try to address whatever the problems are. Um, I think that kind of thing needs to be expanded quite a bit. Whatever the community need is, try to meet it. And that should be the guiding principle, not We're a capitated program. We're looking to profit from denying care. What can we get away with? Which is the way it is now with managed care corporations.
Thank you.
Thank you, Carlo. Did that cover what you were after?
Yes,
Okay,
absolutely.
okay, awesome, terrific. So it's Tony, right? German?
Yeah. Thanks,
Yeah.
Chuck.
Tony,
Dr.
welcome.
Thanks so much for your presentation. I've been following your work for a while and appreciate your advocacy. I was on the PNHP call last night. Really exciting work as far as this coalition building, as far as, and I think it's the right direction of getting the risk bearing away from MCOs in the Medicaid space is a great start for us to push our agenda. A few things I wanted to share with the group. I've met pretty extensively with Connecticut and the state. I serve on the plan design for the universal healthcare for Oregon. So I'm coming from Oregon. I should have shared that. I'm also a vice president of Healthcare for All Oregon. And so I've had some calls with the former director of Medicaid of Connecticut, Deidre Gifford. And then I met with William Halsey, who's the current Medicaid director in Connecticut. And some really interesting learning. I think as Dr. Kemble shared the benefits of what they've developed there. They are the lone state. Minnesota is in works for that, and New York is moving forward. But I think there's a lot of value for us to think in this. I think one question I had for this group and Dr. Kemble is just, we have over a decade and a half, 2 decades, bought into value-based care. And that is the Kool-Aid, right? And the understanding that there is some value there, right? Not to be a pun for the word of value-based care, but it is that coordination of care. And as Connecticut has shifted, they use an ASO model, which I think is really the ideal nature. But there are some elements in kind of research in my own understanding, my own practice as an organization. I work for an FQHC and seeing, talking with a number of providers in the state of Oregon, is some of the elements that fall under this umbrella of value-based care. One of them is capitation, some of it is pay for performance. The challenge is the gaming in the system with a lot of things, as you've shared with HCC coding and our org, is just doing it. And as far as I can tell, most organizations are doing acuity panels with that. So I think we need to think in us moving forward in this movement, the concern of taking the pieces that are of value in that. And I think it is in that ASO model where it's the coordination of care. But some of the capitated, and this is the conundrum I've had, is trying to talk on the plan design for Oregon's development. Is there's a lot of pushback, a ton of pushback with that. And one of the arguments to be made is that in a capitated model, people can budget. They know what they're going to be getting up front. So as a community health clinic, it's really valuable for us to account for that. And it's a bit of a conundrum, So I just wonder, my question is, what are the elements that we need to account for in our counter arguments against moving away from the existing system? And are there pieces that in the mix of payment structures, if you move just to an entirely fee-for-service, how do we make sure we take the value of that coordination of care and the team-based care, that a capitated model, because that capitated model pays for my nutritionist, behavioral health, my outreach worker, or a mix of those things. And it's just figuring how we do that. And I think we need to answer some of those pieces, and whether it is a fee-for-service for those other specific elements. I haven't come up with the answer, and I'm just curious about how do we approach that?
Thanks, Tony.
Okay. Well, as you know, Oregon also has a task force to look at designing a universal health plan for Oregon. And some of the OPS members from Oregon asked me to submit testimony to their board. And I have all this laid out in a document. I discovered that the chat won't let me insert a document, so I can't share these things. But basically, the care coordination part of having these community-based services, that would be paid with budgets, and they would pay their professionals with salaries. And a physician might be in working for that program a quarter time as the physician consultant to the interdisciplinary team and paid with a quarter time salary. And the rest of their time they could be in practice paid with fee for service. So you would have the independent practitioners paid with fee for service, those that are working for one of these community-based programs or for a community health center, they could be paid with salaries from the budget of their employing organization. And so it would be a mixture of salaries and fee for service. I would favor having, and this Connecticut did this also, having a limited capitation fee paid to primary care practices who have been designated as a care coordinator by their patient. And I would keep it as a limited part of total compensation so that you can make it a flat fee and avoid having to do risk adjustment. Because once you do risk adjustment, you are dealing with a lot of administrative costs. The other thing is that the big problem with capitation, it's not really a budget. I mean, it looks like a budget, but it's a budget for a year, but you're then held accountable for the cost of your patients. You then have an incentive to avoid sick people because you have a risk pool. You have an incentive to avoid sick people. You have an incentive to skimp on care. The whole justification for doing capitation is fee for service is driving unnecessary care, so we need to reverse the incentives and make it profitable to restrict care. But there isn't a problem with excessive primary care at all. There's a problem with severe shortage of primary care. So the whole justification doesn't actually make any sense. So I would use that care coordination fee. That can be capitated because it would be small enough not to need any risk adjustment. And then I would put the money into those resources in the community, paid with budgets with their professionals on salaries, so that you wouldn't have to hire all those people in your practice. You could call a phone number and they would be made available to you free of charge. And that would be much more cost effective. You could run a lean practice without a lot of staff and have those resources readily available, including specialist consults. And you could go to Eastern Oregon, set up a practice and do high-level specially informed care with minimal resources. It would be much more cost effective. I recommended all this to that Universal Health Plan task force.
Did you see
Well,
that,
appreciate
Tony?
that.
Did you see that document? Have you seen
No,
it?
I'd love to get my hands on that
Yeah.
again. I think, Mike had forwarded some stuff,
Right.
but I don't know if I have the exact.
Drop your email in the chat here for us. Okay, that's probably the best way to go.
One other thing I just wanted to share with the group is Oregon has a program called Healthy Oregon. It's covered by our people legislation, and this was covering our undocumented community members. That was moved into the MCO space with our CCOs. With the new HR1 and concern, it is theoretically, so this is something I think about it as our Medicaid. It is on some calls that are on those last week, being considered to move out of an MCO, out of a CCO, back to a fee for service. And I think that could serve as a potential for something of this nature.
Okay. Thank you, Tony. All right. Let's keep moving on. Appreciate your thoughts here. We've got Mike.
Anyone who wants, I'll share the Hawaii Medicaid deprivatization bill and the comments to the Oregon Universal Health Plan board on the considerations for designing a more cost-effective system. Send it to my email, which is in the chat, because I can't post them in the chat directly.
Okay. All right. That's the best way to roll it. Okay. We're going to bring up Mike Huntington, and then there are several other things in the chat. And I'd like to finish this with about 10 minutes to spare because there are some important developments that I do want to touch base on with regards to the work we do here at OPS. This third Friday call, which was originally we were doing this sometimes every week, every other week, monthly, what have you, is that we like to dedicate a little bit of time just to bringing people up to speed as far as the organization's developments are concerned. So if we can get through this in the next 5 minutes, if people can make your questions really crisp and give Steve a chance to just sort of like do a rapid fire, and we'll just go through these questions real quickly. Mike, you're up, and then I'll go over to the chat.
Yeah, can you hear me?
Yep, go ahead.
Okay, I can't pull out my video for some reason. I just wanted to introduce Jim Phelps, who joined us late. He's a psychiatrist here in Corvallis who
Mhm.
has been using the collaborative care model that Steve has mentioned for his psychiatric, the care of mental health patients in this area. Jim, I hope I'm not putting you on the spot. Can you comment a little bit?
I'll just say that's true. And so we have some experience using collaborative care for psychiatric services modeled on the University of Washington's collaborative care program. Um, and it has been running successfully for, I think, about 10 years now. Can say more as requested.
Is this Jim Mahon, Mahon?
No, Phelps.
Phelps, I'm sorry. Okay, because I see a question in the chat. All right, Jim, thank you for that. Mike, does that cover you?
Yep. Mm-hmm.
Okay. Let's go. I'm going to pull, if I can try to make some sense out of some of these chat comments and try to get questions. I guess, leading states, I think, we in terms of adopting Medicare for all, single payer, you want to just rip through the leading states, Steve, or I can do that either way. That's from Jim Mann. Go ahead. I put them in this order roughly. Oregon, Washington, New York. And then there's a mix of others: Minnesota, Maine, California, Colorado, and of course you always run the risk of leaving people out, Massachusetts. But yeah, those are the leading states. I hope, Jim, that kind of covers it. Would you add Hawaii to the mix there, Steve, or not?
Yeah, I would.
Okay. All right. So
My argument here is that I think we should all be. I mean, we have two bills we're submitting this year for Hawaii. One is a single payer bill, which has a clause that delays implementation until we capture waivers to get federal Medicaid and Medicare, Medicaid, and TRICARE money. So it basically is a planning bill waiting for SABUCA, and then it would kick in. And so that's how we're dealing with our single payer bill. And then we have a Medicaid deprivatization bill focused on Medicaid. And I think the Medicaid one is more doable in the short run because it doesn't need all those federal waivers. In fact, a state needs a Section 1115 waiver to privatize their Medicaid department, but to go back to fee for service, they do not need a waiver. They can just do it.
mm-hmm.
And because of the impending Medicaid cuts from federal support, we have a strong reason to push this at the state level right now. And I think if we can do it, it would be a big wedge in the direction of single payer and lay the groundwork for getting SABUCA done as soon as the administration changes.
Terrific. Yeah, thanks for that. Again, I'm just sort of teasing out through the chat here. I'm just trying to make some sense of some of these questions. What am I not seeing? If folks want to just very quickly raise your hand if you have a question that's not been answered, and ask it within just very briefly. So folks, if you can throw up your hands to help me out with the chat. Otherwise, I think Barbara, your hand is up.
Yes.
Very
What do we
quickly.
do about the
Very quick.
South? I mean, the states that are mentioned that are moving toward a Medicaid, a public Medicaid system, and will go toward single payer, like New York and Oregon, Washington, Hawaii, and California, et cetera. They're all in the north, so to speak, or the west, the northeast. What do we do about the South? This is a big concern if we don't have a national health care system, and yet we don't seem ready, even despite the shutdown. We are just so behind the eight ball.
I think that under the current circumstances, that's absolutely true in the recent past. But I think we're heading for a major collapse of healthcare all over the country, and in many ways, most severely in the South. That's going to lead to a major realignment of politics in the next few years. And we need to be preparing for that. And we need to have something to offer. And if blue states can show how it can be done well, the red states are going to be moving in the direction of we need something, and they're going to be looking for that, and we can offer it to them.
Chuck,
Yeah,
I'm
that's great.
available.
Yep.
I'm available to be hired. I'll be happy to, if you pay me to do advocacy organizing, let me know. You have
Okay, Barbara, thank you so much. Appreciate it. Then we
chat.
have Barbara Pearson, and then we're
Every
going to
other
wrap.
Barbara.
Yeah, I just wanted to jump in. I've been on the phone driving, being driven, but I got here in time for this discussion about the states. But I think the Medicaid is can go in North Carolina, South Carolina, possibly Florida. I don't know about Florida, Georgia, not Louisiana, possibly Miss Alabama, maybe
Okay.
even Mississippi.
Okay. Okay.
And so I think the Medicaid thing can go. And Ohio and those states have been using it, have been using single payer in their Medicaid drug formularies.
Yeah.
And
Mhm.
so they've got their foot in the door and they're already red. Anyway,
Okay.
I know
North
you want to
Carolina for many years was the leading example of non-Medicare managed Medicaid without managed care organizations and having primary care be the managers of care. They had the model system that Connecticut based their program on.
Who
Their
is it?
Republican administration recently put them into managed care plans, and it's not working out. So they
Which one is that? Is that
the
Oklahoma?
model and they could go back to it.
Was that Oklahoma? Did you say? I didn't hear that.
No, that's North Carolina.
North Carolina. Well, Oklahoma
Oklahoma
had
too.
something too, didn't it?
Oklahoma, same thing. They used to have non-managed care with primary care managing care, and they recently changed it, and it's not working out.
Mhm, mhm, mhm. Okay, we're gonna cut the questions at this point. Thank you so much, Steve. Do you want to just reinforce how people can contact you for further information? Get, I guess, the slide.
Yes, all of you,
Uh,
instead of putting
I-
your emails in the chat, email me directly with your email information, and I will send you the things I mentioned directly.
Perfect, perfect. Okay, thanks so much, Steve. Really, really do appreciate it, and appreciate your strategic thinking here as well. I'd like to kind of pick up on that thread just a little bit because we're moving into a weekend of presentations at the Healthcare Now conference just outside of Orlando. And we're coming off recently the PNHP conference, and earlier in the summer we had our One Pair States conference out in Denver. And we're also, as I mentioned, as an organization, we're in the process of transitioning the way that we're running the work that we're doing. I think we've modeled for a lot of single payer and other social justice organizations a way to be more efficient, which is to create work groups where we break folks out into areas of interest that really match their interests and desire to learn and share and so forth. So it's been an effective model. But we're always looking for new blood. We're looking for new leadership. We want to diversify. We want to make sure that we are connecting across social justice organizations. Those folks who identify with the single payer movement, we're just not big enough to make this happen yet. That's why we really need to grow our numbers, and that's part of our strategy. And our strategy, as I've shared with many of you before, but it bears mentioning, is that we've got to see that vision of a future where we've accomplished our goals, and then ask very systematically, what is it that we had to do to get to those goals? What is it that we had to do to accomplish transformational change in healthcare, in housing, in childcare, in climate, in war and peace? All these questions need to be thought of together in order to build the necessary political power to win. So that's going to be part of our conversation this weekend near Orlando. And we'll be doing a series of one, two, three panels. We've got a representative coming in from Washington State. That's Catherine Lewandowski, who's our treasurer. And then we've got Lydia Guzman coming in from Colorado. And I'll sort of backfill, just to let people know that there's activity, the important activity going on in numerous other states. Plus, especially for you not familiar with the bill our primary bill that I moved to DC to work on for the last 2 years, the State-Based Universal Health Care Act. We reintroduced it in July. We recruited Senator Ed Markey last fall, which is a real coup. So we have the bill now in both chambers of Congress. And so that, to Steve's point, that once we flip the script, once we get through and past this fascism, and it's going to get ugly, it's going to get more ugly before it gets clean. We have got to keep our eye on the ball. We've got to, work with other partners to make sure that we're doing everything we can to roll back this rise of totalitarianism that I date back to January 6, 2021, right? This coup has been coming at us, and we have got to have eyes wide open. I think so many folks in this work have what I call eyes wide shut, and we think, oh, all we need to do is win the next election, everything will take care of itself. That's not the way this is going to work. We've got to build a movement, And we've got to be very systematic in the way that we're doing that. And so I just want you to know that I'm working on a parallel track with partners to build out a strategic plan based on a strategic vision, based on our shared values, based on a comprehensive understanding of how strategy actually works. This is really the critical, important work that I'm focusing on more and more with each passing day. With that said, we're coming into the holidays, and this is the time of year when most people tend to open their wallets, open their pocketbooks a little bit more. We'd really appreciate contributions to make this work go. We are an all-volunteer organization with the exception of a part-time communications person that works with us. But we really are bang for the buck. Whatever you're able to contribute on top of what you've already done, just want to express gratitude for what you've already done. And again, we're also looking for folks to plug into the work group activity that we're doing. Steve here chairs our policy group. You're welcome to think about joining that because a lot of folks are attracted to those conversations. And then we're reorganizing our other work groups so that we're more intentional in terms of education, in terms of lobbying and advocacy, in terms of developing more effective communications strategy, and as well as making sure that our organization is more and more robust. We're always in search of board members from states that are not yet represented, which is about 10 more states. We would love to have more board members. And we're also looking for folks with legal and accounting skills that'll help us, make our organization that much more robust. Because as we make progress, our theory of change, right, is that it's more likely than not that we're going to get to national Medicare for all, which answers your question, Barbara. We've got to make a national healthcare system, but the question is, how do we get there? And we look at what happened in Canada with Saskatchewan. We look at what happened in numerous other states with federalist systems, federalist governments, federalist constitutions. And this is a proven pathway. And so we've got a number of states that we riffed on earlier that are really doing excellent work, promising work. And we need to make sure that when we flip the script, that we've got the 218 votes in the House, right, and the 51 in the Senate, and a president who's going to sign that enabling legislation. But nonetheless, we're going to keep pushing at the state level, regardless of the progress we're making in Congress. Right now, it's dead weight. It's almost impossible to do anything in Congress at this point. Having said that, this has been a particularly important week because one of our political leaders, our legislative leader, Ro Khanna, as many of you know, has really driven a wedge in the MAGA movement by really picking people. This is revolving around the Epstein files, and it is relevant to the work that we're doing. We'll see where that ends. We'll see where that lands. But I see drip, 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 drip happening, and I think that this can erode and undermine this growth in totalitarianism coming from the radical right. But I don't take anything for granted, and I certainly do not have confidence in the Democratic Party leadership. I'm a student of this stuff for decades. We need to be the ones that do this. We need to pull ourselves together. And that's the strategy conversation that we're going to be continuing going forward. So with that, I just wanted to kind of bring people up to speed, give you an idea of what it is that we're doing here at One Pair States. We're prepared to help lead the charge, but we're not presumptuous. But we do need people to be thinking more strategically and getting outside of the sort of the blinders that are represented by our organization structures, right? We've got to be connecting. This is what the radical right did with the Heritage Foundation, dating back to the Powell Memo of the early 70s, bring it up to the present with Project 2025. I'm talking about movement politics. We need to build that infrastructure at the same time that we build the strategy. We've got to have the platforms, the think tanks, the communication and media centers. We've got to have an electoral strategy, a judicial strategy. All of these things have got to work together. And so that's the work that I'm engaged in. I just wanted to share that with you all as we go into the holidays. To me, I go forward in this work with what I call radical hope, radical hospitality, and radical love. And really what that means is that we've got to be open to welcoming people. This is very much MLK's ideology, right? Martin Luther King. And radical love means that we've got to listen to people. We've got to show some empathy. And especially for a lot of people who even voted for Trump, we've got to figure out a way to connect with people because we share common concerns here. We all need a robust, healthy public healthcare system. And then the other thing is radical hope, which is again that visioning to the future with eyes wide open. understanding what's in front of us, identifying who it is that we're dealing with. But develop, as Mike Huntington says, we need to develop those really critically important personal relationships and build those relationships into trust and into power. So with that, I'll stop and see if folks have any comments, questions, please.
Chuck, you know my spiel about the progressives have got to come out. I have found this in Ithaca is very problematic for me. I've pulled
Sure.
back. It's very depressing. We have got to cross those ethnic, class, and cultural boundaries, form relationships with communities that are different than
Right.
us by going to the leadership in those communities, having them bring us in, listening, absolute listening, and using storytelling.
Sure.
And then whomever can handle it, giving them the support to come into the movement at whatever level they can come in, giving them tools to speak with their legislators. That's my spiel, and it goes on deaf ears. And I have a storytelling workshop that
Yeah.
my email is in the chat because I am looking for work, and I'd love to work using my skills of advocacy, organizing, research, editing, and coordinating.
Absolutely.
Please feel free to send me an email, and I will be happy to send you the storytelling workshop.
Beautiful.
But if we don't come out of the cubicles, one more thing I was going to add to what you were saying about Ro Khanna was Massey, who's the Republican from Kentucky, and he has been working with him side by side, and I'll use decent in quotes, but there's a person in the Republican Party that we could join forces with or have him come to us, you know.
Yeah, absolutely. I mean, strange bedfellows, who cares, right? We need to win.
It
We
doesn't
need to
matter.
identify
Right.
those who share our concerns and values. So thank you for that, Barbara. I appreciate it. I dropped my email in the chat. If you want to be kept in the loop as far as the strategy development, we would love to get feedback. We're putting together a one-page document that really, it's kind of like a prospectus, right? This is what we are doing, and we want to get buy-in. We want to get people really understanding that we've got to connect all of our social justice issues in order to build the political power, in order to build the relationships that you're talking about, Barbara, in order to create that shared vision. We've got to see past this crisis and see what it is that our society needs to be, and then ask those very constructive questions. How did we do it in terms of leadership and resources and planning and communications and so forth? So that's the work that we're doing. And honestly, I'm not seeing it happening in other circles, in other social justice circles right now. So I want to let folks know that there's a real opportunity here, and let's roll up our sleeves and get to work on this. Knowing that we're going into the holidays, but stay tethered, stay connected, love each other, welcome family, and have a very healthy time, with your loved ones. So thank you so much. And again, please consider making contributions above and beyond what you've already done, or if you haven't yet, please help how you can. Thank you so much.